Regards to all friends of Dental XP. One of the common aesthetic problems in our practice is the gummy smile. The current parameters indicate that a smile can be called gummy when more than 3 millimeters of gingival tissue is exposed when smiling widely. However, the gingival smiles can be classified as mild, moderate, and severe according to the degree of gingival exposure. In any case, the gingival exposure correction is mandatory from the aesthetic standpoint. It is important to know the etiology of gingival smile, which can be dental, microdontonia, labial, thin lips and concave, gingival hypertrophy, skeletal, maxillary prognathism, or a combination of two or more etiological factors. According to the etiology, treatment options may include periodontal plastic surgery, lip repositioning, orthodontics, orthognathic surgery, or a combination of the different options. If the gummy smile is mild or even moderate, correcting the problem could be given just by periodontal plastic surgery. But in the case of severe gingival smiles, a combination of two or more clinical procedures may be necessary. A very effective alternative is the combination of plastic surgery and periodontal lip repositioning. We present the case of Marjorie, a 20-year-old who has a severe gummy smile, where we must do more than perform aesthetic crown lengthening to treat her gummy smile, as it would be too much tissue to remove, causing collateral damage, such as the loss of keratin and the lack of bone support, mucosa, and would violate the principle of proportion, resulting in elongated teeth. That's why in this case, we decided to use the combination of periodontal plastic surgery and lip repositioning. Formerly, we performed a facial analysis to determine the etiology of the problem and to analyze the facial thirds. We can see that there is a very good facial proportion, leading us to believe that the etiology of the problem is not skeletal, but gingival and labial. The analysis of their lips at rest indicates a medium lip with a dental exposure of 7 millimeters, exceeding the average dental exposure at rest for women, which is 4 millimeters. And the broad smile shows us an extremely high upper lip line with a statement of gingival tissue from 8 millimeters on average. The periodontal plastic surgery technique is widely described and supported by many studies. However, there are a few studies about the techniques of lip repositioning in dentistry, despite being first described in facial plastic surgery literature in the 70s. Contradictions for this technique are thin periodontal biotype because they usually have little keratinized mucosa and this can cause recessions. Strongly concave lip because you may become more concave and cause overexposed incisors at rest. Very thin lip that has very little muscle which can limit mobility. Then we start with the lip repositioning surgery. We perform a bilateral cut of the alveolar mucosa with connective tissue of second premolar to second premolar on the contralateral side to reach the muscle fibers, being aware not to touch them. The lower line of the incision has to be at the junction of the keratinized mucosa with free mucosa. The band of mucosa containing fibroblasts, neurovascular tissue, adipose tissue, and minor salivary glands. Once the band of tissue is removed, muscle tissue is exposed. You can clearly see muscle fibers of levitator labii. We get clusters of muscle fibers with 4 to 0 visceral suture, uniting groups of muscle fibers and making a muscle periosteal suture. The labial frenum is kept as a reference point. We work on our upper lip lifter and common lip lifter and the wing of the nose. Without touching other muscles such as the buccinator and orbicularis oris, because what you want is to limit the rising of the lip, but not mobility. You can see the muscle fibers stitched in the clusters. Finally, we link the edges of the initial incision and we suture to the height of the papillae, prevent deformation of gingival contour. Limiting of the upper lip lifting is immediately given by the muculo-periosteal suture and later, from the third day, because of partial necrosis of the cluster's sutured muscle fibers, partial death of fibers by narrowing, the effectiveness of the procedure is such that the lip lifting can be limited to 5 millimeters. After 3 weeks, we made the periodontal plastic surgery. We make marks on the zenith points of the new gingival contour with the tip of the explorer. These marks serve as a reference for cutting. A clean cut is made, giving a suitable architecture to new gingival contour. If we need recontouring, as in this case, we do so with a new scalpel blade. We should change the scalpel blade after cutting 3 pieces to get more efficient cutting. Incision finished. The gingival tissue is removed. Before performing 1 incision to sever secular epithelium. Junctional epithelium and connective tissue if necessary. Gingivectomy done. You can see the shape and height of the new contour. We prepared margins which will serve as a reference for recontouring and osteoplasty for the alveolar bone crest. Marginal preparation finished. We lift the flap. Recontouring of the crestal bone is performed, leaving the margin of the crestal bone to 3 millimeters of marginal preparation all around. It is important to recreate an adequate bone architecture and shape and volume, as this ensures the marginal stability in medium and long term. We measure all the new contour of the bone to ensure that you keep a distance of 3 millimeters with marginal preparation. This measurement must be taken irradiated, i.e. placing the probe shaft in the center of the buccal surface of the tooth to measure, because it could take wrong values. Repositioning and suturing the flap. This technique of aesthetic crown lengthening with marking the margins is currently under study. It allows us to dramatically reduce the time waiting for prints and also greatly improves the periodontal prognosis in medium and long term. After 2 weeks, we can already perform the impressions. Previously, we obtained a gypsum model of the new conditions of the tissues in which we make the necessary recontouring of the teeth, and then a diagnostic wax-up that will serve us to get a silicone guide for making the veneers or eventually to make temporaries. We perform recontouring of the teeth, which we have made the same marks as we did on the gypsum model. We try to be as conservative as possible and only remove the necessary amount of enamel, polishing the enamel with a fine-grained burr. Recall that the gingival margins of the teeth were prepared in the gingival surgery. A retraction cord number 20 is gently placed into the sulcus individually for each tooth. Then is placed a braided retraction cord number 1, which can be a single long cord. We remove the retraction cord. The ligged silicone is placed into the sulcus and over the margins. And the tray is seated. We take the bite registration. Working model and lab process. The margins are delimited and prepared. The incisal index from the original wax-up is used for contouring, length, and to guide the incisal edge position. Stratification of the material layers. Primary shaping, where we adjust volume, contours, and axial inclinations. Secondary shaping, where we define the area that reflects light forward and vertical depressions. Tertiary shaping, where we give the surface texture. Veneers are finished on the test model and ready to be tested in the mouth. Cementing with modified isolation. Case complete. And the patient is ready to improve their quality of life and achieve her dreams.